Good evening, all the viewers. Today's topic is management of abdominal injury. Whenever you talk of abdominal injury, do not think ever that only abdomen is involved. This is a general injury that is known as polytrauma. Most common is a road traffic accident. You must see what was the speed of the vehicle, ask from the patient if they are talking, and then you can see the mass mv, half mv square, the injury, and that is the magnitude of injury. You can see I've seen four slides here, four images where thigh is injured, where whole body is injured. This is neck injury, and there is chest and neck injury. This is a set of battle situation where you can see abdomen is a part of the trauma. So whenever you see such a trauma, see any external bleeding fast and control it, stop it. If the patient is conscious and breathing, be happy. Check the pulse and blood pressure, then start a IV line, collect all the blood samples, resuscitate, and ask him to lift up one by one limb. If he is able to lift up all four limbs, you have ruled out any long bone fracture. Actively, if you can lift up both the lower limbs, you can rule out spinal injury, and then we can concentrate on the abdomen. On the abdominal trauma, you have the commonest is the blunt injury abdomen. Second is penetrating or stab injury. Gonsa is a separate entity altogether where no conservative management is. In the mass casualty situation, things are entirely different where you'll have to prioritize the cases. You keep priority 1, 2, 3, 4 and then proceed in that. However, following the same principle of starting the IV line. If there is an abdominal injury like this, can you make out what is the injury? Very difficult. It looks very superficial. This lady has a pancreatic injury. I'll show you the CT scan of the patient later on. Two patients having surface superficial scratching on the skin surface, but both had severe liver injury. In this situation, if the intestine is already come out, no investigation necessary, you can straight go in and do a laparotomy after resuscitation. In the plan of talk, I'll tell you there are three scenarios in the case when you see the abdominal injury. When the patient is unstable, that means his pulse rate is very high, his BP is very low, and in this situation, you'll have to do resuscitation fast. If there is full thickness bowel injury, that means there will be gas under the diaphragm and person laparotomy, but resuscitate, but you can wait for a few hours. If there is solid organ injury, spleen, liver, kidney, pancreas, they are considered a solid organ. Here they are very vascular, it will bleed, and you can plan how to manage this case subsequently, I'll tell you. Pancreatic injury, I have made it special because it has got very high mortality and morbidity. We will also discuss urinary bladder injury, rectal injury, diaphragmatic injury. At the end, I'll conclude. We get this, there are three scenarios. Number one scenario, when the patient is unstable. Second scenario, when there is peritonitis. And third scenario, when the patient is stable. You just see they're intervening in the circle that all three can be combined together. The basic steps of solid organ injury management are: step 1, 2 IV cannulae to be connected to both the forearms if it is available, or else you have good IV venous access where you can give at least a liter of blood in 4-5 minutes. Demand blood as soon as you put the cannula. Hemoglobin PCV, other test, and infuse renal lactate. What other test? Because most of the patients may be diabetic or other disease, so do all the possible tests which is possible in the hospital. Unstable vitals, then resuscitate, explore the possibility of stable vitals. In other words, what I say, if the patient is unstable, resuscitate and make him stable. Isolated solid organ injury, without an avulsion injury, most of them can be managed conservatively. So during resuscitation, there will be few phases. One, patient will, if you see the flow chart, patient remains stable and remains stable throughout. So that means indicates a slow bleeding and possible bleeding has stopped. Do a CT scan, establish the diagnosis, and then follow. If the patient is stable, coming to stable after resuscitation, but slowly people start falling, means the VP is, the bleeding is continuing. So the CT scan to be done when the patient, if you do a high resolution CT scan with IV contrast, it will be done in just a minute or so, or 5 minutes. You can have a pre-contrast and post-contrast picture, and then once your diagnosis is established, you can go in. If patient is not stable, please do not wait for an investigation. Please go in, open up the abdomen, and then stop the bleeding if it's possible. And in that scenario, there are two. If the patient is very unstable, do a damage control surgery, means it has got two connotation. You do a quick surgery for two reasons only. One, control the bleeding, number one. Number two, control the contamination of the bowel content. So in this scenario, you put pack, compression presses, ligate the bowel, full thickness, full lumen ligate, and both the side to avoid contamination. Shift him to the patient to the ICU, and then we can resuscitate, let it be there for some time, and then we can go in for the emergency, again, second time laparotomy. Whenever you are doing a laparotomy for bleeding, a scenario situation will be like this. Here, do not keep sucking out everything with blood coming out. As soon as you open, quickly move your hand over the surface of the solid organs. Solid organ usually slides over, the hand will slide over, but if you find irregularity of the blood clot, that is in your side. Do not dislodge the clot. And if the irregular surface, you try to put packs and pressure to do the hemostasis. It is required 6 to 12 laparotomy pads are necessary for the local pressure. Better to put intervening layer of omentum or some absorbable tissue material like mesh, so that when you pull out the laparotomy pad, the bleeding will not restart again. There are two means of packing, way to pack. One is resuscitative packing, means you put manual pressure over that till the bleeding stops. In the meantime, the anesthetist will look after the vascular parameters to minimize the loss and resuscitation. If you plan for therapeutic packing, that means you are unable to control the bleeding. Put the packing for 2 days or 3 days, and then for parenteral tamponade, you can go back again to remove the packing. For control of hemorrhage, you must think of shunting, ligating, clamping. These are quick methods. And think of doing a fasciotomy of the limb injury. Abdomen, you can keep the abdomen open. That's a laparostomia, but bleeding, you cannot have the tamponade. Additional method of hemorrhage is, if there is severe bleeding, cannot control, best is put a balloon catheter in the thoracic aorta and inflate the balloon before you open the solid viscous. If you do not this and there is severe hemoperitoneum, patient will quickly go into cardiac arrest and he cannot resuscitate. Another chemical which has come in, used extensively by the US surgeons during the war, is zeolite, is a quick clot. It is temporarily, it is put a tourniquet and apply this quick clot there. Here, even a deep wound, it will stop the clotting. Even if there is big vessels, like for example femoral, other things, it can also stop. It produces exothermic reaction, generate a lot of heat up to 60 degrees Celsius. The whole skin, everything will burn and blood vessel will close, and a nearly 100% effective. Difficult to remove the substance after the application. So better to be very sure that everything is removed, all cloth, everything is removed, and then put this thing. Then you can have another option is coagulation-based dressing like dry fibrin sealant dressing, fibrin spray, collagen application, thrombin spray. Those hold the clot for some time with pressure. What is damage control surgery? This is learned from SIP. When the SIP is on voice, if there is a leak of water, there are many doors in the SIP. You can just shut off the doors, so the leaking will be limited to one place, and you can salvage, at least save the patient save the sailors who are sailing in that ship. Similarly, we think better that life problem is better than a dead patient. Let the problem continue, let the patient survive. We'll find a solution. It is defined by rapid control of hemorrhage and contamination. Second phase is resuscitation to bring the normal physiology in the ICU, re-exploration, do the definite repair, and with this, the mortality is less than 50%. The persistent bleeding and long operative time leads to three things: hypothermia, temperature of the patient comes down below 34, acidosis because no tissue anoxia, and coagulopathy, hemodilution, and other things. This results in 90% of mortality. So when there is multiple life-threatening injuries, acidosis pH is less than 7.2, and the temperature, body temperature less than 34, these things are ideal. So you can restore the temperature in ICU, resuscitate, urine output is good, patient is stable, then you can go in and do the definite surgery. When again you can do shock at the time of presentation to you, hollow viscous and vascular injury organ, I told you the three at the circle, coagulopathy, prothrombin time more than 19 seconds, or PTT is more than 60 seconds. Normal prothrombin time is 12 seconds. Remember, it's a very important thing. You can, besides all these three named vessels, renal, supramesenteric artery, and two common iliac vessels, two renal arteries, rest you can ligate for save life of the patient. Packing can be temporary treatment for liver injury as a part of damage control concept I've already told you. And this is one of the damage control surgery for just ligate the bowel, lumen is occluded. You use stapler for quick closing of the bowel. This is stapler, you can close the bowel. And then in this scenario, if you close the abdomen, there is a chance because ischemic edema will set in and there will be abdominal rise of pressure. And when the pressure is 10 to 20 millimeter mercury, it is mild and insignificant. If it is 20 to 40 millimeter mercury, there will be oliguria and organ dysfunction. And if it is more than 40 millimeter mercury, it requires immediate attention and decompress. This is the simplest way how you can measure the abdominal pressure by bladder catheter. That means each catheter in the urinary bladder. Here you can put a three-way just below that. One will go towards the urinary collection when the whole urine is draining out. A three-way, if you change, it will go to the manometer and one IV fluid. You just irrigate a little fluid so that bladder will not be empty by the time when you are measuring the pressure, and then stop the IV fluid and the pressure gauge will rise, and that is the pressure you can monitor depending on the time interval. Bowel injury full thickness, it is a simple thing. If you open up the abdomen, locate the bowel perforation, and the perforation area must suture it well if it is vascular. If it is not vascular, you can do resection anastomosis or take a wedge of the bowel. So it must be bleeding at that time. And here you must demonstrate the gas under diaphragm because you do laparotomy. You can see that there is chest injury either, there will be hematoma. You can see maybe gas may be very little, some places maybe moderate, and you can see huge amount of gas. This indicates stomach injury because here was half of the abdomen is with gas. If you see this, if you see a gas like this, it is very unusual to see such a gas in the abdomen. Whole thing is gas that is going to the pelvis. And here there are two scenarios, either stomach injury or sigmoid colon injury. So if there is free gas in the peritoneal cavity you have demonstrated, you have to resuscitate, start antibiotics, best way with 3 drugs antibiotics, and anaerobic must be given a cover, do a laparotomy, locate the source of perforation, and the source control is a key in success to the perforation. If source is not located, then you are at case 22 situation, do a feeding jejunostomy, put a drain, or at best you can ileostomy. So that whole small bowel is there for nutrition. Subsequently, you can deal with the scenario. In the abdominal, you will come back. Unstable patient, you have done laparotomy and hemostasis. Damage control surgery we have discussed. Now we'll talk about a stable patient and made stable with the resuscitation. Majority of solid organ injury and other organ injury will come in this phase. We'll go one by one of the solid organ injury. Consider the most solid organ is injured commonly. CCT confirms the grade of the injury. and based on that we can finalize the management. This is the grade of injury which slide I have shown. Grade 1, 2, 3, 4 as all has got up to 3 hematoma and laceration. And if there is, and here you can make it out whether how is the patient and decide. Emergencies, there are two options here. One is emergency splenectomy and second option is splenic conservation. That means don't operate, manage hemodynamically, and then subsequently you can do the, you can see clot is still adherent here. In this, when you are planning a conservative non-operative management, patient should be admitted to ICU. It should be placed needle for oral, IV fluid, blood transfusion, at least 4 bottles should be kept in the blood bank. Continue monitor pulse, BP, respiration. Urine output must be measured hourly, and 0.5 ml to 1 ml per kg per hour is considered adequate. There will be must do HB and PCV twice daily. If necessary, maybe 6 hourly. Only one surgeon must examine the patient, the abdomen. No other people should examine, because more examination, more dislodgement of the clot, and the bleeding will continue. Non-operative management at the time progresses, means you have managed 3 days, that means the success is likely to be better. If the hemoglobin start rising on 2 successive occasions, that indicates there is hemostasis has taken place. It is more stressful for the surgeon to manage conservatively than to operate and remove the spleen and keep the patient in the ward. Issues: when to start oral, when to make the patient ambulant, discharge, delayed bleeding is another complication, and delayed complication like other cyst formation, others can be there. We will deal with one by one during question and answer if somebody has a doubt. I'll show you some of the pictures where spleen, you can see the tear of the spleen with hematoma and hematoma on the perihepatic hematoma. Another, there's hematoma intrasplenic. You can see there's a palpation of the spleen at one area. Tear of the spleen is clearly visible. Here we can see laceration of the spleen. Again, the interportion spleen has gone somewhere. This is big hematoma, perisplenic. This has been a fast case in 2002 to manage this conservatively. This is another large splenic injury, still possibly not devascularization, because there's some part of the spleen vascularity maintained. Another case, spleen is almost small, shrunken, with a big hematoma. This is a case of portal hypertension. Here spleen, here is very difficult to manage because the portal pressure is very high, it will start bleeding and continue to bleed. Another case, so all this situation, you can make it. Conservative management evolved over the last 25 years because of children, they get post-splenectomy sepsis. And that is why in adults have to try to conserve the spleen, and that is why the conservative management come in. In fact, if you manage conservatively, it has become the choice of management, and your blood requirement and mortality is much less than an operative management. In class 4 injury, where it was considered a surgery is a must, what many people have done successfully, only the hemostasis and hemodynamic stability has to be maintained in such scenario. Patients here, when it is enough for non-operative management, when the hemoglobin keeps dropping, when the patient BP comes down repeatedly again and again, the blood availability doubtful in rare blood groups, I think it's better to time to open off. This is one case which I failed to manage conservatively. At 48 hours I opened up, and you can see the large tear in the spleen. See the specimen, the large tear and bleeding is continuing. You can see the pink red, bright red blood which is coming out. Another case where you manage splenectomy. The follow-up, you must do follow-up for splenic cyst, splenic artery aneurysm, and MRI is a better method because of less of irradiation. You can see a splenic cyst on the lateral surface of the spleen. This may be innocuous subsequently, but you'll have to follow up, it get absorbed slowly. Areas of controversy, grade 4 injury almost is resolved. When to start oral, I've already told you. When the patient's rate of laparotomy is less, you can start activity. Better to wait for 2 weeks, and follow-up CT MRI can be done after if the patient is unstable or something else. Liver injury, It is the most vascular organ because you got two blood supply. One is hepatic artery, second is the portal vein. It is the metabolic activity is maximum in the body. So it produces maximum heat, and that is why it can be called as a powerhouse, where it produces the energy and maintain the heat of the body. This is the classes of injury. Every time it is hematoma, laceration, and there is vascular injury. There are three components. You can see when you go to you do surgery. This is a case ultrasound. There is hematoma here, and then you can manage conservative law or operate depending on the scenario. I will tell you again. This is the child I have shown you before, young girl, had a fall, her blood group is AB negative. I thought better to open up. The falciform began a torn and there is a little bleeding. From there, we did hemostasis, put two sutures, patient become all right. This is a medical student, had a very tough time, has got thoracic injury, blunt injury, lung contusion and severe liver injury. Here everything failed. We had to do a right hepatectomy for as a matter of debridement, and he has survived. This is another case for liver injury. You can see he was going behind the truck, and truck put a sudden brake, and he went and hit on the truck behind, and whole rib, clavicle, and all the ribs medial to the nipple are fractured with the fracture of the right elbow area. Same patient, you can see hemothorax on the left side. There is hematoma in the liver, and in this case, we managed conservatively. Elderly lady, 72 years, big hematoma, perisplenic, perihepatic hematoma, subcapsular hematoma. This lady also did well. Small contusion, tear in the liver. You can see grade 4 laceration of the liver. He is also a medical student. He also was managed conservatively. Here, the small school-going girl had a fall from the vehicle, and you can contusion of this thing. Here you must remember the right hepatic vein is also leaking. This is the AoC, which arrow is there. And the same case is a truck fellow head hit to the truck. This is the palpation of the liver, which later on follow up MRI, and you can see he was doing well. This is the same case. This is another case with vascular injury as well. Middle hepatic vein and right hepatic vein in the areas involved. This another case, and here another laceration case, and you can see one fellow had fallen, the whole cupboard on him, and he got injury. The company owner was very much worried about him, but when I reassured, he was happy. Must remember, it is a largest organ in the human body, 1.5 kg approximately. Fixed organ, fixed are more prone for injury, mobile are less prone from injury. Is common in polytrauma. Right-sided chest injury is very common along with this. The major problems are hypothermia and coagulopathy. Most of the liver can be managed non-operatively. So be careful. Same principle to follow as splenic injury, bed rest, IV fluid, and HBPC monitoring, and nobody except the surgeon should examine the abdomen. Operative management carried non-specialized unit as in associated with high mortality and morbidity. If you do a conservative non-operative management, their survival charge and blood transfusion requirement also comes down drastically. Hemodynamic instability in need of transfusion, the indication of surgery and perihepatic source clearly associated with mortality. That means if you open up and perihepatic packing, there will be chance of two chances now. One is bleeding, second is sepsis. That is the cause of injury is more. If possible available, you can do a selective angiogram to the hepatic artery, and then if there is bleeding, these are small spots. You can see that there is a source of bleeding, and then you can put a microcatheter, embolize this. You can see most of the bleeding has stopped except on the right top area, and here everything has stopped. This person also did well. This has done at Pune. Managed 42 cases, only one mortality. Pancreatic injury is relatively rare because we know most of the people they purchase a car now with the airbag, so that any accident airbag will protect their face and upper part of the body. Do you know where from they have learned this airbag? They have learned from pancreas. Is this because pancreatic injury is well protected, and this is the stomach works as a gas balloon, and that's why it's protected. Still you get injury, Most of the injuries is maybe missed injury, and if it is missed injury, and you can see the fat necrosis at abdomen open, this case was referred to us. We lost that case. Here it is classified into hematoma, laceration, and then laceration depending on whether main pancreatic duct is injured or not. That is main pancreatic injury means it is grade 3. Here you can see the pancreas is disconnected at the neck. You can see the portal vein which is number 3 and the pancreas is lifted up ventrally. Kidney is number 2. Here another pancreas is injured through and through till the splenic vein. Another case which was injured, I'll show you because there is AR because post ERCP. Here also there is the same patient with the ERCP. Here you can see there is effusion to the bilateral chest. Patient is very serious and that's why referred to us. They did a ERCP. ERCP shows leak in the middle part of the pancreas, and in this area it has leaked out because focal post-traumatic pancreatitis. They inserted a stent which is across the injury site, and with that also it requires something, but somehow we could get rid of this management without surgery, and the pancreatic stent you can see subsequently. This patient after 2 months of follow-up and 1 year of follow-up, see the difference. He has gone down badly. Now this is looking better. Here's one more case. The pancreas also disconnected. MRI and follow-up. When you do a laparoscopy in this situation, fat necrosis is the telltale sign of this pancreatic injury. There is blood and fat necrosis is equal to pancreatic injury. Here, non-operative management is done in this. Do a laparoscopy, did a feeding jejunostomy, and put a drain to drain out the pancreatic juice. What happened? In the pancreatic juice is coming out, same thing was refed to the feeding jejunostomy, and patient did well. Subsequently, he develops a stricture subsequently. Here, I published this case report, non-operative non-resectional management has been reported the first time. Pancreatic injury management, if the main pancreatic duct is not injured, manage conservatively. If the pancreatic duct is injured, that is open to the peritoneal cavity, best is lateral pancreatectomy. That means the injured site from there, left side, with or without splenectomy you can do, and close the pancreatic duct. That is the main. Grade 4-5, rare, very difficult scenario, laceration pancreas with or without duodenal injury is special centers, and here also you don't do heroic surgery, minimum surgery, just close the thing and ligate the duct, that may suffice. This is the Takeshima classification of the pancreatic injury. Earlier also it's almost the same with the other thing. Kidney injury, I have got very limited experience, but whatever cases I have seen, managed most of them conservatively, never done a nephrectomy. I'll show you a few pictures. There's a big hematoma. One great thing is that the kidney is taking contrast and the kidney is likely to vibrate. Here you see upper portion of the hematoma is not taking contrast, with the lower half of the kidney is taking contrast, still worth leaving it. In one case, liver and kidney injury missed because he had head injury and long bone fracture. They said hypotension because of long bone fracture. When he came back with pain, this side got a CT, and this kidney is not taking contrast at all. There's nothing to do after 6 months. Here, another case of liver injury. Another situation that comes in that there is no solid organ injury on CT and there is blood in this. So, hemoperitoneum, no solid organ injury, no gas means mesenteric injury. If you delay the mesenteric injury, the bowel will become gangrenous, there will be a whole bacteria open up, there will be peritonitis, late peritonitis, a very bad sign. Here, better to do early, do hemostasis, and resection and anastomosis will save the patient. Here, see the gangrenous bowel and the resection and anastomosis in this case. Rectal injury. You must think of rectal injury if there is blood on per rectum or on PR examination. Number 2, feeling of raw sacrum. Bone you can feel on PR means definite rectal injury. In that scenario, you can see one of the rectal injury. It was detected very late when he came to us because he had femoral artery injury as well. So there is diastasis of the pubic symphysis. The fracture sacrum is also injured. You can see the sacrum is injury on the left side. The basic key thing for this surgery is diversion colostomy. Clean the rectum, so contamination of fecal matter to the pelvis cavity will be not there. debridement, if possible, repair. And here, in the bladder injury, there are two types of injury. CT IVU, CT scan or IVU is necessary if there is intraperitoneal leak of contrast, means it is peritoneal injury. There are two types of injury before that, extraperitoneal and transperitoneal injury. This is a IVU, retrograde urethrogram going to the bladder. Its contrast is going towards the extra pelvis side, wall side. This is extraperitoneal injury. No contrast has gone to the peritoneal cavity. Here, next one is, if you put cystogram, it is all over leaking to the upper, above the pelvic brim. That is a peritoneal injury. If it is extraperitoneal injury, just pass a catheter. If the bladder is empty, the bladder will heal. Intraperitoneal injury, a laparotomy must. Repair, locate the bladder. How do you locate the bladder injury? You pass, catheter is already there. You irrigate the bladder with normal saline or 5 ml of betadine. You can locate the injury site, usually in the dome, and suture in 2 layers. The first mucosal suture must be non-absorbable suture, or else it forms stones. Urethral injury, blood clot in the tip of the urethra, fracture of the ribs, pubic fractures. Do not pass a catheter. This is urethral injury. Do a suprapubic cystostomy. These days, people are doing single-stage urethral repair, and that in the expert center only. You can see the usually fracture can be stabilized. With suprapubic cystostomy, you can see the bladder there, catheter is there from that, false catheter. Do a retrograde uretherogram. Do a cystogram. See the difference between the bladder neck and the urethral, proximal most urethral, this is uretherogram, and then you can make a plan. A diaphragmatic injury is very missed, most often missed. Often as a severe injury, fall from height, and here, this case we lost this, missed the injury because he had severe head injury. There's no way to assess. Fortunately, there's no herniation of content in the mediastinum. So this patient came presented late, and we managed it with a laparoscopy and then open up and put a suture because heart was very close. Concluding, abdominal injury is not uncommon. CT scan has almost evolved with a diagnostic tool. Hemodynamic unstable patient, even after adequate resuscitation, needs an emergency laparotomy and hemostasis. Bowel injury means needs a repair. Pancreatic injury needs to be careful and dealt with accordingly, which I've told you. Most of the other can be managed non-operatively. Thank you very much. Let me tell you before I conclude, it takes 3 years to get MS degree and learn how to operate. It takes 20 years to learn when not to operate. Thank you very much.